channel. We're going to be going over a few more cardiology meds. So we're going to go ahead and start with the antiarrhythmics. So of course, given the name, you're going to use these when you have an arrhythmia with the patient. So we're going to go ahead and start off with amiodarone, also known as Amio. And we want to kind of show some side effects that come along with that. So you can have Blue Man syndrome. So we have Blue Man here. We have pulmonary fibrosis, and then you can also have liver toxicity and then thyroid dysfunction with that. The next one on our list is sotalol, and we really underline that A because you also have sotalol with an O for your beta-1 blockers, so you really want to distinguish those small things. And then we have doxylamide, and so with these two, they both lead to QT prolongation. So now we're going to go ahead and move down to inotropes and vasopressors. So with inotropes, so those are going to increase contractility, and under that you have dobutamine. One thing to note that is that's the same med that you use during a stress test. And then we're going to have our vasopressors. So with this you have norepi, also known as Levophed, so Levophed, leave them dead. And then you have epi, and then our vasopressin, which is ADH, it's kind of its mechanism of action. And then phenylephrine. So the reason we have a plus in here is because when you add the two together, you get dopamine. One thing to also note with vasopressors is that they cause vasoconstriction, and therefore they're going to increase blood pressure. So now we're going to turn the time over to Shannon. She's going to go over a few more things with us.
So this is kind of a follow-up from our cardiology, our last lecture, but I wanted to point out one thing. We have 4 meds that are AV nodal blockers. So this means is if we're trying to lower the heart rate, we're going to block the AV node, so then we're firing from the SA node, and we know that the rate at the SA node is 40 to 60, so we're kind of reducing it down to that. So a couple meds that are AV nodal blockers is adenosine. Adenosine is also a vasodilator. We're going to use this in like supraventricular tachy, which makes sense because we have these supraventricular tachyarrhythmias, so we want to bring it down and fire from the SA node. And then also beta blockers, specifically beta-1 blockers, because we know that beta-1 receptors are located on the AV node. So when we block beta-1 receptors, we're blocking the firing of electricity from the beta-1 node, or from the AV node. And then calcium channel blockers, non-DHP. These work by blocking receptors at the AV node. So we know DHP is vascular, non-DHP is the AV nodal blocker. And then digoxin, we know digoxin lowers heart rate, so we don't want to use this as monotherapy because it's a very strong drug. So it's an AV nodal blocker, so you want to use digoxin in combination with beta blocker, another drug like that, to prevent reflex tachy. One thing to note with these 4 drugs, you cannot use them in Wolff-Parkinson-White. The reason for that is with Wolff-Parkinson-White, we have a congenital accessory pathway that's prone to tachyarrhythmias. So if you use drugs that block the AV node, instead of going down to the SA node to fire, or the atrium, we're going to end up actually using the congenital accessory pathway more, which is more prone to tachyarrhythmias. So if you give one of these 4 drugs and your patient has Wolff-Parkinson-White, you may accidentally increase their heart rate because you're just saying, okay, let's take this accessory pathway that has a lot of tachyarrhythmias. So to review, today we went over the AV nodal blockers. We went over a couple antiarrhythmic drugs and talked about how Amio has a lot of side effects, so it's really reserved mostly for an emergency medicine drug. And then the pressors, these are really kind of emergency med end-of-life drugs as well. And then the inotropes and the combination dopamine, which is a very unique drug due to its duplicity with the inotropes and vasopressors. So thank you for